Let's get started. Dr. Garratt and Dr. Parikh is not here yet. Once they will be here, we'll let them take over. Let me introduce myself. I'm Timir Paul from East Tennessee State University, and Dr.
Dallas, Texas, UT Southwestern. We're panelists and just going to help with moderating until our moderators arrive as well.
Our first presenter is Dr. Gergis. If you are here, please come to the podium and start presenting. Thanks.
Good afternoon, everyone. The case is entitled Double Trouble Bifurcation Lesion at the Distal Cap. Clinical data, he's a male patient, 64 years old. He's hypertensive, dyslipidemic, and he's an ex-smoker. He underwent PCI to LED in 2014, and he had a failed attempt of PCI to CTO RCA in 2015. And he was complaining of angina class 3. This is his angiogram. Was, you can appreciate here as a long CTO segment of the RCA. The collateral swelling, there is an ipsilateral collateral from the RV branch epicardial to the PDA, and there is a septal collaterals as well to the PDA also. On evaluating the lesion, we have an ambiguous proximal cap. We have bifurcation at the CTO exit point. We have an intervention collateral septal and a very tortuous ipsilateral one, and a very long CTO segment, more than 20 millimeters. So we have a GCTO score of 4 points. The plan was to go for a retrograde strategy with a reverse cart, attempt the second septal. If failed, we're going to tackle the ipsilateral epicardial collateral, and this is going to be challenging with a careful dissection re-entry to preserve the integrity of the bifurcation. And we plan to use a double human microcatheter if the side branch was compromised, and we adopted a provisional stenting strategy. Corsair and the wire sewn to the PDA and exchanged it with the Fielder XT. The Fielder XT was managed to enter the CTO body, then do the knuckle to preserve the PL branch, and trials for re-entry. You can appreciate here the wires are not over each other. Tried to do draft. Of course, this is not the optimum site to do re-entry. And finally, guideliner assisted reverse cord was done. And RJ3 was externalized, and at this stage, the PL branch was compromised. So we need to wire the PL. A double lumen enhancer microcatheter was used, and the PL was wired successfully through the antigrade approach. 3 overlapping stents were deployed across the RCA. However, we had a dissection at the PL branch, and the patient had severe chest pain and bradycardia. This is the atropine effect. You can appreciate a dissection here. So, PL was stented, tap technique, and this is the final result. And we checked the septal, they were fine. Total procedure time was 195 minutes. Radiation dose was 4.2, and contrast volume was 300 cc. These are the equipments used. Distal cap bifurcation lesion is a challenge, and if a short lesion is present and true-to-true strategy is more likely, we can do antegrade wire escalation into both branches, or antegrade wire escalation into one branch and antegrade dissection re-entry to the other, or antegrade wire escalation into one branch and retrograde into the other one. And if it is a long lesion with more likely to do a dissection re-entry, retrograde dissection re-entry is the safest option, or retrograde dissection re-entry and antegrade dissection re-entry into side branch if compromised and failed antegrade wiring, or double retrograde or double antegrade dissection re-entry. Thank you very much.
Thank you. It's a good case. Dr. Garratt and Dr. Parikh is here, so they will take over for moderating the sessions. And please be reminded that we are supposed to, you did good, we started 3 minutes late, but just to remind that we are using 5 to 7 minutes so that we have 3 minutes to discuss.
Spectacular case, very difficult, and a lot of good technical wizardry there that managed to get you through. I think you always have to be a little sanguine about the radiation exposure at the time of the case. You did a nice job with containing the contrast volume. That could easily have been a 400 or 500 cc case. But 4 grays or more, you have to really be mindful about that. And I like the fact that you rolled your camera around not only to facilitate good visualization of the target lesion, but remembering also that helps minimize risk of radiation injury to one particular part of the skin. The one thing I do think we don't do enough of in these complex cases, CTOs and otherwise, is shutter in the image. Once you've seen the field of play in your diagnostic studies and you have a good idea of what you're after, remember to collimate down and minimize the exposure of X-ray here, particularly when you see a long case coming like this.
Thank you.
Yeah, I think, so again, this is a prime example of long distal cap at a bifurcation. This is where, what we used to do in the early days of antegrade wire escalation or knuckling wouldn't work. And you saw then when you lost the RPL how sick the patient got. And so you really want to preserve branches. The other thing about the right coronary, you cannot knock off RV branches. We have, over the last 4 years, done about 1,200 CTOs, and every time we've gotten into trouble, it's been with right ventricular function, and either hematomas or RV branch, loss of RV branches. So as much as we kind of take them for granted, you can't in these cases. And I think this is the way to prevent losing branches, because if you do anything with wire escalation subintimally, that's what tends to happen in the right coronary. So I think very nice case, well done, and all the tips and tricks that are necessary we utilize. Congratulations.
Thank you.
Shall we go on to the next? Great, thank you very much.
Thank you.
All right, I'm going to invite Dr. Tajti? Tajti. My apologies. Dr. Peter Tajti is here.
No worries.
Tell us where you're from and then tell us what you're going to talk to us about.
So originally I'm from Hungary, Eastern Europe, but I work in Minneapolis for the Minneapolis Heart Institute. And I'm about to talk of a highly resistant proximal RCA lesion and how we managed it. All right. So our patient was an 89-year-old man who was admitted to emergency department due to acute chest pain. Myocardial infarction was excluded. However, the patient underwent PCI multiple times in the proximal LAD circ due to prior myocardial infarction. And also the patient underwent multiple interventions in the proximal RCA due to multiple restenosis. And the patient had coronary risk factors as well. We found mild disease in the LAD and proximal circ. However, the most severe lesion was the proximal RCA, instant restenotic lesion in, yes. We delivered an all-star guide wire to the distal rumen, and we performed pre-dilation with 3.5 millimeter non-compliant balloons with pressures up to 28 atmospheres. However, we failed to fully dilate the lesions, and we decided to use shorter balloon length with larger diameters with increasing pressures, but we kept having the same result. So we knew that we faced with a balloon undilatable lesion, and this is the current algorithm that we are using for treating such phenomenon. First, initially we performed an intravascular ultrasound showing MLA of 2.6 square millimeters. And we used upfront laser technique with and without contrast, simultaneous contrast injection. Using simultaneous contrast injection is an off-label use. However, it is a feasible and excellent option for dilating under expanded stents or previously implanted stents with undilatable lesions. However, this failed, and our next approach was delivering multiple body wires to the distal lumen and using the wire cutting effect that inflating balloons with 2.5 to 4.0 millimeter diameter with increasing pressures, but these tries also failed. We moved back to the laser technique, but we kept on failing. Hence, we decided to use simultaneous balloon inflations with a 2.5 millimeter NC balloons with 24 atmosphere pressure, but we had the same result. So our next technique was using rotablation with 1.75 Burr over a rotafloppy wire, which was just exchanged using a microcatheter. However, we still saw some underexpansion, and we upsized the burr to a 2.15 millimeter diameter, and we used multiple plastics with it. However, they lasted less than 10 seconds because the patient was complaining of some chest pain. And we finalized our results with 3.5 diameter of angiosculpt scoring balloon with its spiral cutting blades, and we were able to achieve MLA of 5.1, and finally we optimized our results with some post-dilation controlled by IVUS, having an excellent final angiographic result. In conclusion, balloon undilatable lesions can occur frequently in contemporary non-CTO and CTO practice as well. And these highly resistant lesions usually require several treatment options and techniques for the successful revascularization. Rotational atherectomy only can be used in instant restenotic lesions as a last resort option. And lastly, algorithmic selection of all these techniques can facilitate lesion crossing and dilation. Thank you very much.
Peter, that was great. Great case. I have a quick question for you, and then I wanted to know what Dr. Parikh thinks about my second question. The first question I have for you is, you said that when you finally got to rotational atherectomy,
Yes.
you had to keep your burr runs with a 2.15 millimeter burr short because of chest pain. Is that right?
Yes, so the patient developed some chest pain and during the whole case, some bradycardia was also noticed. We had temporary pacemaker, so temporary pacemaker was inserted. Usually we rather use aminophylline, but in this case we used temporary pacemaker, but the patient still had some chest pain, and that's why we decided to do very short passes with that huge burr.
There is a funny, thing that happens that we still don't fully understand when we introduce unusual energies into the right coronary system, particularly like vibration, like heat. Strange things seem to still happen. We think they're tied into parasympathetics and so forth, but we really functionally don't know. I think we have learned, though, that we can treat these folks successfully if you medicate them either in advance or chase after symptoms with aggressive medical therapy can usually get through. And the other question that I had for you, but I'm interested in knowing what Manish's thoughts are. This algorithm kind of reaches for somewhat less used techniques for fracturing refractory vessels. I think many of us would have gone earlier to, say, rotational or orbital atherectomy. And I'm just wondering what your practice is like and what your thoughts are about that algorithm.
Yeah, so for underexpanded or non-expanded stents, it's, number one, hope that you never get into that situation by doing plaque modification up front so that you could expand properly. But when you do get into that situation, I think laser is a very good option. I think remember that the laser has different catheter sizes, and there's a photoacoustic and photochemical application here, where if my 0.9 laser had not worked like yours didn't twice, we would have injected contrast and essentially created a microcavitary explosion to try to get it. I think putting 225 NCs almost never will work. I think what I would have done first is put the sculpt and gone up to 28 atmospheres. I've only broken or ruptured one sculpt, and it really tends to work well. The other thing you could use is a chocolate balloon, which is the most non-compliant balloon you have. And the third, which I've done in the last month twice, is a new Wolverine cutting balloon, which is much more deliverable than ever. Would have put a 1-to-1 and gone up very high. And actually, I've had 2 cases. Again, these are all anecdotal cases. But as Kirk said, in days gone by, all we had was rotablator. And whether it be basal gyrus or whatever, funny things happen. You got to be prepared. Patients are very uncomfortable. They almost always get bradycardic. And in this particular case, you got a beautiful result, but you also have to be prepared. If this gives, it may give full through, and you might have a perf. Mm-hmm. So you've got to have a JOMED ready to go.
Yes.
You shouldn't be looking for a JOMED after it happens, because when you start, you got to be able to finish.
And putting one of those things into that lesion would not have been a joy. Sir?
So, I know we don't have it, but is shockwave going to work for this? Or is it not going to fit in there?
Well, this is the type of lesion that it's meant to address. But jury is decidedly out on
Are
this.
they doing this in Europe, like with shockwave?
It's the type of lesion for de novo calcium, not for ISR underexpanded calcium. So we don't know the answer to that. So it is going to be a nice new option. It is a very bulky system. So if you can't get it there, you can't help. So we're going to see once the trials start.
Just one of the suggestions for laser is you can get more energy with a bigger laser catheter. So a 1.4 or 1.7, you'll need a bigger guide, but that will give you more ablation power to be able to potentially break the stents, which is what you're trying to do.
That's a great point. And I just only want to reflect that in our algorithm, we are actually including at the same level of using angiosculpt and the cutting balloon and the chocolate balloon that you mentioned, because those are excellent tools dedicated for these type of lesions. In this case, we use angiosculpt but yep, thank you.
Great case.
Thank you very much. Okay, Dr. Wei Zhang, thank you very much. Dr. Zhang is going to talk to us about transdistal radial access concerns and issues. Tell us where you're from and give us a little bit of an introduction to your talk.
Good afternoon. Originally, I'm from China. Right now, I'm a third-year resident at Princeton Biopsy Medical Center in Birmingham, Alabama. And today, I'm going to talk about not really a challenging case, but a new technique that will probably make your challenging case become easier in the future. I'm trying to start this.
Go to the lower right there, click on the icon with your name. Down and to the right.
Oh. Okay, thank you.
Practice clicking the keyboard. Put the mouse over it and put the keyboard hit it into it. Clicking the mouse and not hitting it?
You can click on your mouse and see whether
Someone from IT is there we go.
Yes, just keep up.
Okay.
Yeah. So my first of all, thank Cardiovascular Innovation for this great opportunity for me. My topic is about our experience of applying distal radial access as a primary access for a wide spectrum of interventions.
Who's the arrow? Up, down, arrow?
Okay. Sorry. It's too early for that now. Okay, I'll talk about the concept, the technique, and the illustration of the wide applicability. So transdistal radial access procedure was first mentioned in 1980s, but its application in cardiology was first prescribed by Dr. Kamani in 2017 from Netherlands. So up to date, there are a total of less 200 cases described in the literature. Recently, there is a growing interest on distal radial access, largely due to social media. This is an example of Dr. Ahmed, which was my mentor's Twitter page. So talk about the anatomy. We're talking about transdistal radial access through the anatomic snuff box, which is a triangular area on the dorsal surface of the hand. Anteriorly is the extensor pollicis brevis. Posteriorly is the extensor pollicis longus. The base of the snuff box is formed by the scaphoid bone and trapezium bones, on top of which is the distal radial access artery. On your right side is the demographic showing the actual puncture site of radial access and distal radial access. In addition to the routine advantage that radial access has over femoral access, distal radial access also gives more comfortable position for the patient. Also is more comfortable for the operator being able to stand on the right side. We are able to avoid using the dominant right hand for most patients. It's also an easier coronary cannulation by using standard Gergis catheters. Theoretically, there is also less risk of ischemia or bleeding because the puncture site is more distal to the origin of superficial palmar branches, which gives more circulation to the hand. The way we set up at Princeton Baptist Center, we have a few videos to share with you. Let's see if I can play here. So this is the first video showing our way to set up the patient with the left arm supine and close to the right femoral area. So this setup is very similar to the right femoral access. And it gives a strong support, stabilization of the left arm. So next video is our critical step by using ultrasound guidance for distal radial access.
Is that a 5 French sheath you're using?
We have used 5, 6, 7, all of them in the real practice. And at the end of the procedure, we just simply use a tip top and wrap with compression tapes. This can be removed after 2 hours, at the same time without any restriction to patient's wrist. And remember, the patient can use the right arm immediately after procedure. And no restriction to the wrist of the left arm as well. So by this setup, we have been using distal radial access, particularly on the left side, for almost 300 cases as the primary access, including routine angiography, routine PCI, CTO. We have been using 6, 7 French, also catalysts, both antegrade and retrograde approaches. We also used it for complex PCI, also primary PCI for STEMI. We used it for adjunctive IVUS, FFR, OCT. We use it for placement of the distal embolic protection device during TAVR procedures. That is through the right distal radial access. Also, we have strong support in aircore septal ablation. This is an example of with oversetup and left distal radial access, we have strong support during aircore septal ablation. We also did a complex PCI in both left main and right coronary artery. The first case is showing a rotational atherectomy with a 7-French catheter in a female patient who has an impeller support from the right femoral access. The lower bottom part is the RCA intervention. We did atherectomy, also get nice final results. The limitations, like any new technique, there's always a learning curve. Also, currently there's a limited availability of dedicated hemostasis aids, and it requires a dedicated cath team that are willing to do this. In conclusion, our experience support that using particularly left-sided distal radial access can be a appealing option for both common and complicated cases. This picture is a newspaper report from China, who is a visiting cardiologist in our hospital, learned this technique and went back to China, did first case in his city. At the end, I would like to thank to our CAS team for the teaching, and also my teaching attending Dr. Van Marine and Dr. Mustafa Ahmed, who is sitting there today. This is the end of my talk, and I would like to answer or get teaching from you. Thank you.
Thanks. It's a good case, but I did not still, the same advantage you mentioned for the anatomic snap box from the left radial, we can do the same advantage. Just look like femoral. You can go to the left radial in the same way. Patients can use the right radial, and I don't see any added advantage of using the snap box, using the one couple of millimeter distal. What is the true advantage that you are trying to?
True advantage is, first of all, is patient can have a more comfortable position with, first of all, we don't have to, with left radial access, the patient's hands is kept on the left side, and with this radial, patient's hand is supine and close to the right femoral access, so it's more similar to femoral access, also without restriction to the wrist. This is also, as a, maybe I should go back to that picture.
I saw the pictures, but
yeah.
You can use exactly the same on the left radial. You just get the access going to the opposite side, and you put your left arm. And most of the places, the people who use the left arm and left radial, they're using as a femoral access. Like they put the keep the arm close to the same way, exactly the same way you're using the close to your femoral with all the support.
This also theoretically has the less risk of bleeding and ischemia, because as the picture showing here, the distal radial access is, the puncture side is more distal to the origin of the superficial palmar branches, which provide an extra blood circulation to the hand. Also, the operator also does not need to bend over to the left side during the procedure at all.
Can I ask, do you have any experience yet with complications? A 300 case volume is a good start, but at a low incident rate, you might not have seen all the complications to be seen yet. With a radial artery, even with patent hemostasis, 5% or so may occlude, and while the hand survives that, you can end up with pain syndromes and the like. That can be a problem. Do you have any sense of whether the snuff box reduces that risk or any other of the risks that we see with routine or traditional radial access?
That's a great question. So we are aware that there's about 5% of occlusion risk in the routine radial access. So according to our preliminary data now, our complication is at least less than 5%. It's maybe 2.5%, but eventually we are actually have an ongoing project. I'm working with the fellow in the hospital to continue follow-up on all these 300 cases with ultrasound guidance to see the long-term outcomes.
And I would guess that with any hematoma developing here, you'd have a different sort of compartment to be concerned about. I guess I have to confess I don't know the compartments of the hand well enough to know what I would need to be worried about, but I'd be worried. If you had a hematoma, and I'm just wondering if you developed a hematoma here, you have that happen in the traditional radial puncture site. Usually, if you apply a second occluder device proximally, that tamps it enough and you're done. What is your strategy here if you apply your pressure compressing and yet a hematoma develops? What is it? Just a manual hold then and get the hand surgeon notified, or what's the approach?
So this is really, first of all, according to my knowledge, in the triangular area here, there's not much nerves going through. And the base of the snuff box is actually the scaphoid, and the trapezium bone is on top of the bone. But really, practically, I would like also see if my mentor has some answer for this question.
He's done a great job with all this himself. You know, the big advantage is, you know, when you do left, so I did left radial always for years now. But you set up as a femoral. You don't get access, get your cath team, so you annoy the cath team much less, which is very important. But also, you're just there. It just starts here, you're sticking it, you don't have to turn around and stick. I would never, you know, we've like switched completely. We can't imagine not doing it now. It's become that. You know, it's not just, at the beginning it was a gimmick, hey, look what we can do over here. Now it's become standard. With the bleeding, the compartment is very interesting. It's a completely different distribution of compartment. So, you know, 350 cases, at least 1% hematoma, nothing required surgery, nothing even approached a compartment. Most of these you can get off the table with manual compression. And when the hematoma does occur, it sticks it's interesting. It sticks distal to the radial over here and just goes in the hand. You just place compression, put their hand up, put some warm on it, and then an hour or two it's gone. I've never seen one that, once again, 50,000 cases might be different. But, you know, and he's doing a radial follow-up on everyone, ultrasound. It's about 2% so far with 300 cases, so very reassuring. But, you know, these are all great questions about where the hematoma forms, and very interesting.
Well, terrific. Well, thank you very much. Really an interesting topic. Appreciate your bringing it forward. I think we better move on to the next presentation by Iosif Xenogiannis. Is that close?
It's Iosif Xenogiannis, actually.
That's what I was going to say.
Yeah.
But I hedged, and now I'm embarrassed. If you could just please tell us where you're coming from and introduce us to your topic.
Yeah, okay, so I'm coming from Greece, Europe, and I've been working for the last 3 months for Minneapolis Heart Institute Foundation, Minnesota. Can't really find can't really find my. Okay.
There you go.
Oh, here I am. Okay, great.
The keyboard maybe works better if you just use keyboard.
Which key actually? Okay, here we go. Okay. Apologize for this. So. So, dear Chairman, ladies and gentlemen, I would like to thank the organizing committee for giving me the chance to present this case to you today. I would like to describe a case of a challenging retrograde crossing for a CTO lesion. Okay, so 50-year-old patient with a previous intervention for PFO presented with stable angina, class 2, sorry, and the initial angiography demonstrated a distal RCA CTO, so the patient was referred to our center for vascularization. We can see here the initial angiography. Proximal cap was bland. The lesion length was about 60 millimeters long. The distal vessel was diffusely diseased, and we can see the presence of septal interventional collaterals. So the original plan was to try antegrade wire escalation, and in case of failure, change to retrograde approach. So we tried multiple guide wires, but actually antegrade wire escalation was not successful, so we changed to retrograde approach. However, crossing collaterals was really challenging, and we changed also multiple guide wires, but we finally managed to cross into PDA by using a field RFC and a Caravel microcatheter. However, the distal vessel was diffusely diseased, and there was a bifurcation at distal cap. So our guide wire kept entering PLV instead of distal RCA. So we were forced to change again to antegrade wire escalation. And this time our guide wire crossed subintimally into PLV, as you can see here. So next, we used a twin-pass microcatheter, double lumen microcatheter, and we were able to cross with a Confiance Pro 12 subintimally into PDA. As you can see here, right here. So next, we advanced the Hornet 14 retrogradely, and by inflating an antegrade balloon, we were able to perform guide catheter extension reverse cart by passing our Hornet 14 through a trap liner. Afterwards, we externalized an R350 wire, and by using IVUS, we were able to demonstrate that its position was in true lumen. And then we were able to perform percutaneous coronary angioplasty. So we deployed totally 3 drug-eluting stents from distal RCA all the way down to PDA. But as you can see here, the flow was limited to PDA, implying probably the presence of a subintimal hematoma. So afterwards, we tried multiple balloon inflations, and we were able to achieve a TIMI3 flow. And finally, we employed one additional drug-eluting stent distally. You can see here our final result, and in order to conclude, in cases of diffusely diseased vessels where the lumen is not visible, the retrograde technique is critical for entering the vessel. However, in our case, we used antegrade wire escalation in addition to retrograde crossing. Specialized equipment like twin pass is very useful in case of bifurcation presentations at the distal cap. And finally, we have to keep always in mind the hybrid algorithm, be flexible, and change techniques if we want to be successful. Thank you for your attention.
Good. Another complex tour de force on a complicated bifurcation lesion requiring antegrade and retrograde techniques. It sounds like when you entered the distal right coronary segment, the PDA segment, with the wire through the retrograde approach, you just simply could not get it to turn left and get into the distal right.
Exactly,
Right?
exactly. Yeah.
Even though you were able to eventually get antegrade into the posterior descending, but into the posterolateral branch vessel from the RCA.
But only after using a double lumen microcatheter.
Yeah.
This was, let's say, the secret of success in this case, I think.
Key move.
Yeah, the key move, exactly.
Yeah, that's a good approach. Questions from the audience on this case?
Do you have any long-term follow-up these patients?
I'm not really aware about this patient, but I think that through all his, let's say, stay at the hospital, there was no adverse events for him. I'm not really aware about the long-term follow-up, to be honest with you.
The CTO registry does have long-term follow-up, and multiple publications have come through regarding retrograde subset of those patients, which is about 25–30%, And you're specifically asking about in-stent restenosis, or TLR. And TLR rates are in the low double digits, 11, 15, 12, 13%, which are, could they be better? Yes. But for the types of patients we're talking about, quite reasonable. In this particular case, I think doing the technique that was done was, as Kirk said, a tour de force, but a very nice result was had. Clearly, these patients have higher TLR rates than our standard complex PCI patients. There's no doubt about it. But I think that the results with contemporary DS are quite acceptable.
I noticed that you exceed almost 6 gray radiation. What point you would stop?
Yeah,
Is this a reportable case?
Okay, yeah. After 5 gray, we are about to stop, the procedure if we don't have a lot of progress. But I think that for this patient, yeah, it was a really challenging case. But I think that finally we were close to success. So we continued. The patient, that's for sure, 5 gray are enough. So he have a follow-up after 1 or 2 weeks in order to see if there is no problem, there is no cutaneous, let's say, inflammation. But I think that in this particular case, because we were close to success after so many minutes that we spent, we continued with the cost of more radiation. Yeah, this is a good point. I have to admit it. Yeah. Thank you.
Terrific. Thank you very much. Okay, Daniel Feldman, are you here?
You guys missed the 2 p.m. one? We skipped.
Ah, yes, I have. Thank you very much. Michael Magali. You must be Michael.
Hi.
It's so good to see you. We were worried. We looked everywhere. We waited and waited.
Yeah. Lots of bringing up, right?
Well, I apologize.
No problem.
We did skip you. Can you tell us where you're from and
All
introduce us to your
right.
talk?
My name is Michael Magali, and I am from Minneapolis Heart Institute, I'm a cardiology fellow in Minneapolis Heart. And I have nothing to disclose, unfortunately. Well, proceed with that. So today I'm presenting. Good. So today I'm presenting a case about an ad hoc left main PCI. And I'd like to start with a quick question, excluding the MHI people. So in your institution, is it common to proceed with a left main, ad hoc left main intervention? Common?
Show of hands if you do this regularly.
Show up. No? All right.
Show of hands if you have a standing policy that discourages ad hoc left main intervention.
Yeah, that actually was my second. That actually was my second question. Is it a crime to proceed with an ad hoc left main intervention?
I think my experience is that you go, if patient comes in and he needs the procedure done, you get everybody together and proceed. I mean, you just don't do it, just as without any problem. Whenever you do it, you can do it, but I think you need a surgeon and some other colleagues, they agree and you do it.
Yeah, I think
Yeah.
I mean, I'm from a
Speaking
small
of-
town. I've done it sometime like we did not have at that time our open heart surgery, so they pick up the phone and talk to the cardiac surgeon and tell him the patient.
And just proceed.
So give the moral support.
Sure. I think most of us are lucky enough now to have evolved a relationship with our surgeons that something like a heart team is possible. Not everyone, but for most, I think that's true. We can get that kind of communication done quickly and efficiently. The real challenge for us is that we tend to sedate patients early in the procedure. As soon as the timeout is done, everybody's confirmed, we're ready to go. We like to get the patient comfortable. And then the problem is, how do you do a proper informed consent?
I'm describing those patients who were crashing back.
No. This is elective ad hoc PCI, right?
Those,
Yeah.
Yep.
Those you can do it, but I think it's not urgency in that.
Yeah. Well, let's hear the case.
All right, so Ms. Z, she's a 62-year-old pleasant lady. She came in with 2 months of progressive exertional dyspnea. She has no history, no cardiac history, no PCI, no history of CABG. She had a dobutamine stress echo for about 8 minutes and some EKG changes, but a new inferior lateral wall motion abnormality. So we proceeded with the angiogram, and as you see, a 99% mid-circ lesion. And in the same angiogram, we can kind of get a hint about the proximal left main disease. So proceed with other views, and here it's more obvious, about 70% proximal left main. So we decided to proceed with imaging. We used IVUS, and we got an MLA of 5.6 millimeters square. At this point, apparently everyone would hold off and talk to surgery, right? So we proceeded with risk assessment. Syntax score was very low, was 12, and syntax 2 was 24.6 PCI, 20.6 for cabbage. So we decided to proceed with the intervention. So a Samurai in LED, Marvel in the Circ, proceeded with emerge pre-dilation, and then, a premier stent and post-dilation. This is the final result of the Circ lesion. And then we used an NC for pre-dilation of the left main. And then we used the Promas Premier, deployed at 21 seconds at 20 ATM. And then again, we used the IVUS to assess the PCI. And then quickly, we decided to use the osteoflash balloon for the aortoatrial, for the aorto-osteal lesion. So as you see, the osteoflash balloon is pretty neat for the aorto-osteal lesions. So in multiple studies, I've shown to increase the MLA post PCI, and most importantly, it frays the edges of the stent to the aorta, so it helps re-engagement of the left main. And this is our final results. So, in conclusion, I would say ad-hoc left main PCI in patients that have complex disease is reasonable, and IVUS should always be used in left main disease, and the osteoflash balloon can facilitate the vessel re-engagement. Thank you. Sure. Shall I start this again?
The advantage of doing an MC dilatation before left main stent, because you are putting other stents in and out, fine. So why we have to, before we put a left main stent?
Why would we use
The MC.
the emergency? I think this was used at discretion of the operator at that time, and we maybe for the proximal left main and NC would have made a better sense in this setting.
Yes, question.
We know that the osteal lesions are predominantly fibrotic, so some operators prefer to dilate the
use it.
osteal lesions with a non-compliant balloon first. I have a question regarding the type of stent used.
The Premier?
Premier, because there is a reported foreshortening with this type of balloon after post-dilatation. I think, if I remember the number, is around 15% foreshortening, longitudinal foreshortening after post-dilatation. So he did IVUS after the post-dilatation. There was no.
We did IVUS before post-dilation to just assess the opposition, and then after post-dilation with the osteoflash balloon, we did not use the IVUS now.
So the question about why using a non-compliant balloon is a little peculiar to me. Why would you not use it to prep the left main?
Every other was going in and out, and if you use it, what is the advantage of this is? You are going to go and dilate it, and if you have to do it subaxial, you can do it later. And I think what I would not like to use it, suppose you create a dissection before you put a stent in, and that will make the things complicated.
Suppose you put a stent in and it's not expanded. Then what do you do?
Then use a nonsense.
Then you can operate on the patient afterwards. So the whole point is to make sure that your left main stent expands maximally. So if you're going to vessel prep, you better vessel prep before the stent goes in. So that would be the step to do, not to do.
I guess I'd like to back it up one step further and ask the question, why the left main at all? At almost 9 minutes on a pharmacologic stress study. I'm not sure what the time means in that. But the patient didn't have, sort of terrible symptoms, had 1 millimeter of upsloping ST segment depressions in the infralateral leads. and had a tight OM lesion.
Yep, that could be the
Sort of
culprit.
done, aren't you?
Yeah, but
I guess, you know, the reason I'm asking the question, and I'm asking it knowing there is no correct answer, but I think we as interventionalists have to have, you know, a very open mind about the changing ability, or the changed ability to manage even these critical lesions in patients using intensified medical therapies. You know, it's not an us or them kind of debate here. And my guess is a left main that's got a 5.5 millimeter diameter lumen in a patient who presumably now will be asymptomatic. Now that may not turn out not to be true. That changes things. You take the patient off the table and you see the patient back in a month and they're doing everything they want to do. They're perfectly fine. You know, the natural history of that kind of fibrotic, stable-looking left main 70% disease is not that hair-raising. But the complications associated with intervention with left main, although uncommon, are decidedly hair-raising. I think we have to be sanguine about the state of affairs here with this kind of disease.
Question for Dr. Parikh for my education. Suppose you did put a balloon and did not dilate, did not expand it. So what would be the next step to do in this osteal disease?
Then you figure out why it is. You can use a scoring balloon, a cutting balloon. If that doesn't work, you have atherectomy.
In an osteal lesion?
Yeah, absolutely.
Imaging would be the next step.
Imaging is the critical part of that.
Understand what-
But putting a stent in without knowing it can expand, especially in the left main, is equivalent to malpractice for us, right? You don't want to do that. So especially here, as Kirk is saying, and something that's potentially a borderline case, right? I mean, the culprit here was not the left main.
A lot of times, sometimes it has been shown that this kind of patient, the revascularization that fails, like with a bypass, you know, because the left
Yes,
was
I
not
was just
treated.
going to make that comment. I think the flow down into the LAD would have made, you know, put in a lemur graft problematic. But something that could help in sort of getting you an indication would be if you did an FFR,
Yes.
and there was, you know, ischemia or, you know,
Kirk, if this
obstruction.
5.5 had an FFR value of 0.75, would you treat it?
You know, I guess I wouldn't feel it was inappropriate to treat it. But again, I come back to looking at the totality here, not just chasing a number or a value. You know, this patient, we didn't get all the detail, but presumably the patient is doing well, now has new symptom, you know, et cetera. And I think we found the culprit and treated it nicely. I just raised the question of whether or not we are being sufficiently measured in our approach to this kind of disease 100% of the time. I think the answer is we could do a better
FFR
job.
will change for left main before and after dilating the OM?
I'm sorry, repeat that?
Is the FFR going to change
Oh, after you,
before and after dilating?
in the circumflex, it
When
will.
would like,
Yeah.
when would like to do that FFR?
Yes, if you want to isolate the impact of the left main,
Yeah.
then you want to have, ideally, no disease in either the LAD or circumflex distribution. So the way to do that is to treat the OM lesion and measure the FFR across the left main.
And I think the consensus is that in this borderline case, I would definitely do FFR before doing the left main PCI. I would do FFR in both. After fixing the SARC, I'll put a FFR in the LAD, FFR in the SARC. If there is a doubt, it's a borderline IVAS results. And I was not sure, is that not a bypass candidate? I know that syntax score is pretty low. Just in
Syntax is 12 and
Yeah. But,
syntax 2 is 20.
Is it a lot of comorbidities or is not? a
No, she
candidate?
does not have comorbidities.
So
but
Sergeant said
she
this-
was felt to be low risk for PCI as well on the same case.
The PCI was appropriate care for left main if it warranted treatment.
Mm-hmm.
We should go on.
Good.
Okay, thank
very
you.
much.
Nice case.
Nicely done.
Our next speaker is Dr. Feldman. Please introduce and tell us what you're going to present.
Sure. My name's Dan Feldman. I'm also from the Minneapolis Heart Institute. I just started as a structural fellow, so I'll be actually presenting a case from my interventional fellowship at the University of Illinois at Chicago. All right, so this was a 91-year-old male veteran with severe aortic stenosis coming in for a coronary angiogram prior to a planned TAVR. Past medical history is notable for severe peripheral vascular disease in his bilateral lower extremities, so actually that precluded a transfemoral TAVR, so the plan was going to be for a percutaneous subclavian TAVR. He was symptomatic with dyspnea on exertion, worsening exertional capacity. Normally EF on echo, he had criteria for severe aortic stenosis. His SCS risk of mortality was 8.5%. He was pretty adamant he did not want any surgical intervention. He just wanted TAVR. Didn't want any surgery at all. So we start with the diagnostic angiogram, 6 French right radial access. You can see he's got severe osteal OM disease. There looks like there's probably some hint of proximal circ disease, and you can also see the proximal LAD is heavily calcified, and there's disease there as well. Just another caudal projection trying to show that proximal circ. You can see here probably a little bit more convincing that there's severe disease there, although it's still a little less than ideal image. As far as the LAD, clearly severe, heavily calcified proximal lesion. I don't know why this freezes for a little while, but more distally. More distally, you can see that there's a severe disease there as well. That's also probably at least moderately calcified. RCA also has severe proximal disease, but not as calcified as the other disease. So, I mean, at this point, when you have severe 3-vessel disease, you always have to ask, should we abandon this plan for TAVR in favor of CABG or surgical AVR? But the patient was very clear that he did not want any surgical intervention, and before we kind of had this discussion, he just wanted PCI, which we felt comfortable proceeding with here. Question before TAVR often is, which vessels and what lesions you have to go after and revascularize. I think here we're pretty comfortable saying he had major vessels, severe proximal disease. We're comfortable saying that he really needed each of these lesions treated. Sometimes you might want to go after the easier lesion like the RCA for kind of some low-hanging fruit rather than the more complicated stuff first, just so you have some sort of vessel being perfused, but we really thought the left-sided territory was a little more important and wanted to start there. Impelled support wasn't really an option because of his peripheral vascular disease. A balloon pump really wasn't going to help us too much. We're a radial center. He did have bad peripheral disease. Probably could have tried a PCI femoral, but we were comfortable just staying radial. Figured we needed atherectomy at least for the LAD. Weren't sure about the circumflex system as much. So for the LAD, we wired it with a rotofloppy, took a 1.5 millimeter burr. Did 2 passes on the proximal lesion, also decided to hit that distal lesion as well, just because it was calcified. We were able to easily expand a balloon down there after atherectomy, and then in the distal lesion, we put a 2.5 by 20 millimeter stent. We got a nice angiographic result there. For the proximal lesion, we hit it with that 2.5 NC balloon on the way out before we stented the distal lesion, and then after we put that distal stent, we dilated it some more with a 3.0 NC balloon. Positioned a 3.0 by 22 millimeter drug-eluting stent. Approximately, thought we had a landing zone there in the proximal LAD. Tried to land it kind of before that aneurysmal section after the lesion. Deployed our stent. Had a pretty good result. Wound up post-dilating it with a high-pressure balloon. We were pretty happy with our final LAD results, given what we started with. Decided to move on to the circumflex next. Our question here was really what bifurcation strategy we wanted to employ, whether we'd need atherectomy, and we figured that we would benefit from some intravascular imaging. So we went ahead and IVUSed the circumflex just because we weren't really seeing it well on angiography. We were able to confirm that there was diffuse disease in that proximal segment involving the bifurcation. It was calcified. MLA was 3.96, so we were pretty convinced this was a true Medina 111 and that we needed a 2-stent strategy up front. We had a wiggle wire in the LAD from the LAD intervention, left that in place for support. We had the OM and the circumflex wired, tried to pre-dilate. You can see here, we didn't get very good expansion. There's dog boning of that balloon. So decided we had to go ahead and atherectomize the OM lesion. So we pulled our wires out, switched out for a rotofloppy, went with the same 1.5 millimeter burr, did a couple passes for that OM lesion. Rewired, or we exchanged the OM wire for a wiggle wire and then rewired the circumflex. This time we were able to expand the lesion pretty well. For bifurcation, we kind of wanted to keep it simple at this point, minimize our wire exchanges and because it was kind of a long procedure at this point. So we just went with like a simple mini crush. So we deployed a stent in the OM, a 2.5 by 15, extending back into the circumflex. And then we actually crushed with a non-compliant balloon, which actually kind of caused some problems for us instead of crushing with the second stent, because it doesn't project very well here, but we were having a lot of difficulty delivering the stent to the circumflex after that. We thought we were getting caught up on that first OM stent. So what we had to do is interworm a guide liner down and then unsheath our stent, which was a 3.5 by 18 millimeter stent. So we deployed it here, did kissing balloon inflation after that, and we were pretty happy with our final result in the circumflex. So we called it a day for that, brought him back a few weeks later to do the RCA PCI, which was a lot more straightforward. Just wired it with a Xi'an blue, pre-dilated with a 3.0 by 15 NC balloon. And then we went with a long 3.5 stent, just covered the entire disease segment, and had a pretty nice result on the right. So the patient tolerated everything very well. Initially, when I submitted this case last month, he was scheduled to have the TAVR this month, so I was going to show the results of the TAVR. But he actually felt so much better symptomatically that he postponed the TAVR and is kind of now refusing it. So kind of a good end, I guess, but he's still got severe aortic stenosis. So thanks.
Very good case. I have a couple of questions for the panels. One question is, how high risk when you have a severe aortic stenosis and if you have a multivessel disease to do the PCI? Just not particularly this case, suppose you have a peripheral artery, no peripheral arterial disease, one. Or second question is, if this patient not multivessel disease, just mid-LAD lesion, 90%, or mid-circulation, or both mid, or one area proximal severe lesion, do you just do the TAVR first or do the PCI first?
So, you know, in our lab, it seems to waver case by case. Things that change your decision making is LV function, heart failure symptoms or not, and the criticality of the coronary disease and what you're going to need to do. I've seen it both ways, where they will do a BAV and then proceed with the left system like you did here. And I think, by the way, that was a tour de force of getting the left system done all in one shot. I've also seen the opposite, where they'll do a TAVR, get the patient through, and then bring them back and select the coronaries to be treated. So I don't know what you're doing, Kirk, but you know it really varies on a number of different aspects of the patient and the care and what they're coming in for.
We tend to address the coronary disease first. That's our usual approach. But you're right, Manish, there's a lot of different ways of going about it, and there's arguments in both directions. Quick question, what was his aortic valve area estimated to be?
0.95.
0.95, yeah. The reason I ask is we all know that AS is like the thinnest device to go out, you know, dancing on. And this is one of the settings where I think the old Brown-Wall criteria of 0.4 millimeters squared per meter of body surface area is a really useful number to have in your hip pocket, because once patients have a valve area that's less than 0.4 per meter squared, their tolerance of the kind of work that you did just vanishes, or it's dropping at a precipitous rate. So in a guy, he's probably had a BSI of, you know, an average guy's going to be 1.8 or something. So you're talking about a valve area then kind of 0.6, 0.7 range, which I think most of us would say that feels right. You know, a valve area in that range, they just don't tolerate anything. And I applaud the work that you did. Is an extraordinary outcome for this very sick guy. I do think that you had an angel sitting on your shoulder through these cases, because rotational atherectomy and an LAD with a sick as stink circ and a sick as stink right and a guy with bad AS, boy, I tell you, that just makes me sweat thinking about it. Yeah, nice job, very nice job. I do think that if his valve area had been a little worse, you would have had much more trouble. And I understand he's 91, he doesn't want to get an operation and so forth, but let's not forget, the whole idea of integrating patient preference and so forth does not mean that you are a vending machine. Your duty is to explain to the patient their best option and push them in the direction of making the wisest choice. Now, he may refuse, that's fine, but you have to document clearly that you had all the facts laid out and explain things to the patient and the family in terms they understood to confirm that they've made a wise choice.
I have a question for you.
Sure.
So if this patient did not have a peripheral vascular disease, would you put Impella in this case, or how
Yeah, I
difficult
mean, that's
would
another
be
thing
think
with
that with the severe AS, Impella, crossing the Impella and putting that do you have any practical experience on that?
I don't. I kind of asked my attending about it, and in his experience, it's been done.
It's not well tolerated.
Yeah.
The whole system tends not to function very well when you've got aortic valve disease, even though it's stenosis more than regurgitation. The valves are diseased. They're thickened and rigid. Once you put a big device through, if it holds the valve open, you get so much AI. That,
Okay.
So I want to call out my structural fellow who just graduated. Poonam is in the back there. She's 4 weeks out of her training. And Poonam, how would you have done this case? Or how would you do it now if you had this multivessel disease, normal ventricle, critical AS? What did you take away from your... Yeah. Is that what we would have done? BAV in this case? Yeah. 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 Yeah, I mean, I think that's just what you had said, Kirk. With that, you know, an angel's got to be sitting on your shoulder to get by without something, you know, with a fixed cardiac output and doing, you know, rotational atherectomy and having that, you know, that circ bifurcation.
Nice
Good
work.
point.
Great.
There are certain patients who are critical to stenosis and they are asymptomatic. You know, maybe his symptoms are all from coronary artery disease, not from aortic stenosis.
Maybe so. And
Could be.
one, if he feels great,
Could
after
be,
coronary
yeah.
work,
Yeah.
leave him alone. Yeah.
And other question is, it comes into our mind when we do this procedure as well. Like stent in his LAD, there were post-stenotic dilatation, you know, aneurysm. Sometimes you have to leave a stent in, and obviously you can't oppose that stent to that area. So what is the long term in this kind of experience?
As long as you have good optimal expansion and disease coverage, there's no downside.
No, but optimal explanation in a stenotic area, but an aneurysmal area you cannot.
As long as the stent is optimally expanded, there's no price to pay. That's what we've learned from imaging.
I think we best move on to our next case. Thank you very much again, Dr. Feldman. Dr. Mohammed Khalid? Dr. Khalid will come to the podium next. Kind of interesting topic here. I'm looking forward to learning something. Tell us where you're from and introduce your topic.
Hello everyone, my name is Mohammed Khalid. I'm one of the third-year resident at East Tennessee State University from Tennessee. I have nothing to disclose, and my topic is atrial septal endocarditis complicating tricuspid valve endocarditis. So I have objective to recognize the atrial septal endocarditis in patient without any atrial septal defect or patent foramen ovale or any device closure for patent PFO as well. Role of transesophageal echocardiogram in the diagnosis of infective endocarditis and atrial septal endocarditis, and role of the medication in the management. So I have 26-year-old male with medical history of Hep C, tricuspid valve endocarditis, and IV drug abuse. He had a tricuspid valve Staph aureus endocarditis 4 months ago, which was treated with prolonged course of antibiotic. He had a TTE at that time that showed 1 centimeter tricuspid valve vegetation and moderate tricuspid regurgitation. And there was no involvement of atrial symptom or any congenital atrial septal defect at that time on the TTE. So he admitted with complaint of progressive shortness or breath and non-productive cough that has been going on from last 2 weeks, associated with pleuritic chest pain, fever, weight loss, and decreased oral intake. Patient reported recent IV drug abuse 2 months ago. He denied any hemoptysis, night sweats, any incarceration, recent travel, tuberculosis exposure, or history of positive PPD or HIV. His exam, he was hypertensive, blood pressure 95/53, tachycardic 102, respiration at 18. He do have decreased breath sounds at lung basis. His labs was significant for AST and elevated mild transaminitis with alkaline phosphorus 356 and total bilirubin of 1.5. He do have mild lactic acidosis, which trend down to 1.6. And the WBC counts for 14,000. So he had an X-ray and a chest CT. You guys can see that on the X-ray there were multiple foci, bilateral, and same also on CT scan as well. So they read that it could be consolidation, it could be septic emboli or metastatic disease, or maybe it could be vasculitis, granulomatous with cholangitis. And the same findings were found on the CT scan as well. So he was thought to have either recurrence of endocarditis or maybe persistent of previous endocarditis, which he had a few months back. He was starting on IV fluids and antibiotics. He had another TTE that showed mild right ventricular enlargement, and there was decrease in the size of tricuspid vegetation from 1 centimeter previously to 0.67 into 0.9. Probably that vegetation has spread to the lungs as a metastatic septic emboli as well. So he was scheduled for TEE to evaluate for either persistent or complicated case of endocarditis. TEE showed aquedense mass on the atrial septum, most likely endocarditis, and there was 1 centimeter a flap on the top of that mass that moved back and forth in the right atrium. And there was also small tricuspid vegetation as well. So this is the TEE that show the mass attached to the atrial septum and the 1 centimeter mass on the top of that as well. So he had positive polymicrobial blood cultures, E. faecalis, and then Streptococcus H. parainfluenza. He was continued on antibiotics because we don't have any clear-cut guidelines on the management of atrial septal endocarditis in patients who do not have any AST or PFO. We do have on the rest of the endocarditis with more than 1 centimeter if we have fungal vegetation, if there is perivalvular abscess, but in that case, there was a complex making decision regarding the further management approach. We consulted cardiothoracic surgeon for any recommendations. They said continue the conservative management with antibiotics with plan to repeat TE in 1 month. The patient stayed in the hospital, had another TE. That shows some decrease in the size of vegetation from the previous one. And he responded well to that. Because we talked to the family and they were concerned about that vegetation, so they want some other opinion from another tertiary center. So we talked to Vanderbilt, and they recommended same conservative management with plan to repeat TE after discharge in 1 month. So he had a third TEE that showed almost complete resolution of the vegetation, and there was some mild tricuspid valve vegetation. So I do have videos of each TE in the sequence. So this is the first one. So you guys can see this vegetation is moving back and forth in the right atrium, and this is the atrial septal vegetation as well. And that's for the second one. So there is some decrease in the size of vegetation with antibiotics as well. And that's for the third one, which he had 1 month after discharge from the hospital. So almost complete resolution of the vegetation. So what is atrial septal endocarditis? It can happen as an isolated event or with AST or PFO as well. It has been reported following percutaneous closure of PFO device with PFO and AST as well. It's very uncommon to see atrial septal involvement without any congenital defect as well. And there were only a couple of cases reported with that AST. And some of them called set-let lesion or maybe alien in the heart as well. They called different names. It's very rare and some unrecognized complication of tricuspid endocarditis, and there was only one case of complicated with mitral valve endocarditis as well. So it's an interesting case of endocarditis complicating tricuspid valve and with septic emboli to the lungs as well, diagnosed by Duke criteria. So it has been reported in literature associated with the mitral valve endocarditis. Not every patient with tricuspid endocarditis complicated with atrial septal involvement, but it is important to consider TE to rule out any other concomitant structural valve abnormalities and atrial septum as well. There are different factors that can involve in determining the progression of vegetation from the tricuspid valve to atrial septum. That include the size of the vegetation, degree of the regurgitation, volume and velocity of regurgitation, and host response to infection, and the wildness of the microorganism as well. And the pulmonary involvement is very common with the right-sided endocarditis. It has been reported in 10 to 15% of cases, mostly with IV drug abuse. Like in our case, he was IV drug abuser. And some cases have been reported with non-IV drug, like in hemodialysis patient. So the take-home point to consider TE, to closely examine the cardiac walls and other structure to rule out any concomitant vegetation with the tricuspid valve or mitral valve endocarditis. Because our patient, he had a TEE first, and they didn't see any vegetation. They said that was normal. And might be we could have caught that earlier and treated with medication as well. And the second is that most of the right-sided endocarditis treated medically, but they recommended that if the patient has PFO or atrial septal defect, you should consider surgery because there are high chances of going to the left atrium, maybe to the septic emboli to the brain as well. But our patient was lucky because he didn't have any atrial septal defect or piriform overall. So we considered medical management in his case. Thank you.
That's a great case. I was just curious, did you do any provocative tests for PFO? Because you may not just be able to see it with color Doppler. You may have to give bubbles or...
I think they did a bubble study that was negative. There was no any
PFO.
bubble.
And no aneurysmal change to the septum, see, right?
Yeah, yeah,
No septal aneurysm.
yeah. Because
That's an interesting case, and of course, the underlying sad part of this is you got a young fellow with substance abuse disorder and comes in with a polymicrobial event at age 26.
Yeah.
Tough. Well, it sets a stage for a lifelong misery for him, even if he's able to shake his disorder. And in terms of surgical indications here,
I was looking for that. I couldn't find anything regarding that.
And can you give us a sense of what the surgical indications would be?
So you can, just like any other case, you can either remove the valve with a patch to prevent the vegetation to be formed, but they're hard to be form a vegetation with the patch as well. But I couldn't find any clear-cut guidelines regarding surgical management. But as I said, that most of the cases have been treated with medications for the right side endocarditis. And he was lucky that he had on the right side as well.
His question was indication for the surgery. So you already mentioned that one is PFO, and if there is a PFO associated PFO or ASD, and if you have an actual septal endocarditis, then it's an indication for surgery because there's a high risk of stroke.
Mm-hmm.
Yes, with
Structural
PFO.
erosion, abscess formation,
Yeah.
those sorts of things.
Yes.
Any other questions from the audience?
How long she was on antibiotics?
Previously, he was on 6 weeks, and then continue on that on discharge for 6 weeks as well, and follow with IDS and outpatient as well.
Thank you. Our next speaker is Dr. Velagapudi. He's talking about an 80-year-old man with chest pain.
Hello, everyone. As Dr. Parikh mentioned, I just finished my structural training at Columbia end of June, and I'm on a couple of months break traveling the world before I start work.
We're all jealous now.
I had planned this before I started my interventional fellowship. So I submitted this when I was a fellow, so that's why you see Columbia. All right, I got nothing to disclose. This is a case of an 80-year-old man who presented with chest pain to one of our attendings' office, CCS class 4 for 2 weeks. He has a history of CAD, multiple stents to the LAD, 2 in 2005 and 1 in about 7 months before his presentation. Had a TAVR with a 26 millimeter S3 valve 6 months prior to presentation. And his post-TAVR gradients were 7 millimeters. COPD, hypertension, hyperlipidemia, prior CVA, and no residual deficits. So this was his presenting EKG, right bundle branch, left anterior fascicular. It was normal sinus, normal heart rate. So this is, these are films from his TAVR was done at an outside hospital. And you can see the first image on the left is the valves being deployed, and then the image on your right is post-deployment angiography shot. Not very great, but you can see that the left system is pretty open. So our workup included a limited TTE, which showed an EF of 40 to 45%, no significant wall motion abnormalities, and the aortic bioprocesses was not well visualized. The right heart cath, pretty normal pressures. Left heart cath gradient across the valve was 13 millimeters, and the valve area was 2.3 centimeters squared. This is the diagnostic cath. So you can see ostial left main disease, pretty obvious. And then in the left cusp, you can see some tissue just kind of compressing the ostium of the left main. The LAO caudal view, the spider view shows this better. You can see the left main's almost 80% occluded at the osteal level. The stents in the LAD are patent. He also has other disease, OM2, 100% occluded, and the first diag is 80% stenosed, but he had this disease prior. So this is the right with minimal luminal irregularities. So at this point, our differential diagnosis was coronary artery disease, which you can see seems less likely. He did not have any disease prior to TAVR, and 6 months, maybe too short a time to develop that unless it was an ACS. So it could be thrombus, could be dissection, but again, this is almost 6 months out and less likely, and he was taking his antiplatelet regimen pretty regularly. And the other differential was a native valve tissue compressing on the ostium of the left main. So we thought this was the most plausible etiology. So we took him off the table, had a heart team discussion, and he was considered high risk for CABG. So the plan was for left main intervention. So the next question in our minds was whether we need to use mechanical support up front or not. And if we did not use, do we get access? And if we did get access for an Impella, should we cross the valve or not? So given that his EF was 40-45%, it was stable angina, and there was no significant right-sided disease, we decided we would not put an Impella up front, but we did get contralateral access. And we crossed the valve and placed a pigtail. So these are his iliacs, good sized, pre-tortuous. And so we put in a 14 French sheath in his left femoral artery, used an R4 straight glide wire, crossed the valve, and switched it out for a pigtail in the LV. So if we needed, we could just put in an Impella quickly. On the right side, we got an 8 French access, and went ahead with a JL5 guide, and we wired it with a BMW wire. It wasn't easy. We had to use a microcatheter. We used a Turnpike LP, but we did finally wire it. And after wiring, just for good support, we pulled out the BMW and switched it out for a wiggle wire. And we started off initially with a NC Quantum 3x15. This is the IVUS run after the initial 3x15 balloon, and you can see the cross-sectional area is only about 5.8, not really well expanded. So we used next size 4x15 balloon and dilated it again. And so at this point, we decided to stent, and the question was, which stent do we use? Because we wanted a stent that would give us good radial support and not compress from pressure from this tissue that's the native valve tissue. So I just have, it's interesting, 2 screenshots here of radial strengths of various stents. On this, you see Synergy stent seems to have the highest radial strength, followed by Zynes or Zero, and then Resolute Integrity, whereas on this, Resolute Onyx has the higher one, and Resolute Integrity, Promise, and Zynes seems to be at the bottom. But anyway, we decided to go ahead with the Zynes, and we used a 4x28 stent. And you can see after the stent was placed, the ostial left main is still not very well expanded, and the tissue seems to be compressing. There's some compression still present, and we thought that this radial strength may not be sufficient. But anyway, we IVUSed, and you can see it's still not well expanded. So we went ahead and post-dilated with a 5x15 NC Quantum. And we still were not satisfied. So at this point, we had a discussion and decided that we need a second stent. But before that, this is the IVUS run. The cross-sectional area was good, but it's still some compression from that tissue. So the second Zynes was a 4x15, and we post-dilate with an NC Trek 5x15. And then I'll show you the final result in 1 second here. This is the final IVUS run with a cross-sectional area of 15.8. Much better, though still there's some compression, but And then these are the final angiographic shots. And so we had to put the stent, extend the stent outside the ostium. That's what's been suggested by prior case reports and studies to prevent the radial compression by the tissue. So he did well, no symptoms after this.
It's a good case. Good that we use the Edward sapien, but if it be like core valve, then it would be a nightmare, first of all. And finally, it is a very good result. But do you think that is there any AI when you deployed the sapien valve before? There was some space in between, but look like it's a perfect place. Like the orientation of the it's like 80-20 or maybe 90-10. It was not. What was the height when you deployed? I don't know if you remember or not. Or the like the from.
You're asking of the coronary height or the valve?
No, coronary from like the. Like the coronary height, like 14, 8, 10.
Oh, it was around 12, but this was done at an outside hospital, so it wasn't our
outside.
Measurements, it was from outside.
Okay, probably that's. You have any other question?
I'm just wondering, it sounds like this coronary intervention took place about 6 months after the valve was placed, is that
Correct, yeah, the tower was 6 months prior.
Did you have any follow-up CT imaging of the valve that gave you information about that?
No,
placement of the native valve tissue?
no, there was this angiography shot after the valve was placed, and it was at an outside, and that clearly showed there was filling of the left main. And his symptoms started 3 to 4 months after the valve was placed, and it was progressively getting worse.
Yeah, it's undoubtedly you have the right diagnosis. I have to admit, I thought that was a dissection when you showed the first injection, and I was, again, getting sweaty. I'm sweating a lot.
How often do we see this, Poonam?
It's not very common. It's there was a recent paper in JACC, I believe, out of 18 centers, they had 17,000 patients, and it was 0.2%. So it's not very common, and especially the late delayed are much, much lower.
Are you doing anything different with his antiplatelet therapy now that you have double layer stent in the left main with a prolapsed valve there as well?
Aspirin,
and also
ticagrelor.
something there around the valve that may serve as a nidus for clot formation.
Correct.
Are you doing anything different?
Yeah, we weren't doing anticoagulation because we know this is valve tissue. We just did a dual antiplatelet therapy.
Question, yes, sir.
Do you modify such stents after the procedure? Because I don't know how will you get in the next time if there's something wrong.
So from the prior case reports and that paper, they say the stent has to extend beyond the ostium. We really don't use much of an osteal flash because you want that stent to stay open and prevent the radial compression. So I guess you have to work around and just try and engage it. You have about 1 or 2 millimeter stent protruding outside. So we have to work around and just kind of engage it.
If I'm not wrong, did you say that you prefer ticagrelor than Plavix and than clopidogrel, and that's why? What was the reason?
Sorry, say that again.
I think that you said that you used the double antiplatelet therapy with aspirin and ticagrelor. Is this correct?
Correct.
And why did you prefer ticagrelor instead of clopidogrel, let's say?
Just because there's 2 layers of stent, and ticagrelor has a higher
Because it was also left main?
left main.
Well, thank you very much. Really
Thanks.
terrific case.
Thank you.
Okay, Dr. Khalid is going to come back for our last case. We are running a little bit behind, so Dr. Khalid, if you can, please do your best to present this as nicely as possible.
I'm back. I have nothing to discuss. So this is another interesting case of a rare coronary artery anomaly. So malignant course of single coronary artery blessed by unusual region. So I have a 71-year-old male with medical history of hypertension, hyperlipidemia, diabetes, family history of coronary artery disease, chief complaint of chest pain and shortness of breath. He was seen in the clinic for those symptoms that has been going on from last 3 months. So we thought that could be unstable or stable angina. His history was kind of inconsistent with the symptoms. So he was scheduled for an elective left heart cath for which he came to the hospital. His vitals were stable and exam was pretty benign. He do have some basic labs which came back normal, had a normal ECG as well. So he had an angiogram that showed anomalous origin of single coronary artery from the ascending aorta above the left sinus of Veselva, and that gave rise to the RCA and the left main, which divides into the LAD and left circ as well. So in order to confirm the coronary artery and to look for further details, he had a 3D CT angiogram that confirms the above finding, and it also showed the malignant course that was in between the aorta, interarterial course between the aorta and the pulmonary artery, with 50% RCA stenosis in the interarterial course as well, and subsequent course into the right atrioventricular groove as well. So that's an angiogram picture. You guys can see there is a single coronary ostium and a single coronary artery which divides into the RCA, and the left main which further divides into the LAD and left circ. So this is a 3D CT picture as well, which show almost the same findings which we found in the coronary angiogram as well. So here you can see that this is the ascending aorta. Here is the origin of single coronary artery, which give rise to the RCA, which goes in between the aorta and the pulmonary artery, and the left main, which further divides into the LAD and left circ as well. So during the angiogram and the CT scan, he was completely asymptomatic. So we did an access test to determine does he have any signs of ischemia or any symptoms. And he remained asymptomatic, and Duke determinant score was 7. So due to lack of the association and the patient preference, we opted for conservative management for this rare coronary artery anomaly. So anomalous single coronary artery. Coronary artery anomalies are very rare, 1% of the general population, with an incident rate of 0.3 to 1.3%, and the rarest variety is a single coronary artery with prevalence of 0.0024 to 0.004%. Anomalous region of RCA is a rare congenital anomaly, has been associated with other congenital anomalies like tetralogy of Fallot, transposition of great vessels, PDA, pulmonary atresia, but our patient doesn't have any of these. And most of the patients diagnosed either incidentally because of the recent advance in the coronary CTA, or maybe present with syncope, chest pain, and sudden cardiac death. The clinical outcome depends upon the course of the artery. It could be interarterial, which our patient had interarterial, and retroaortic, prepulmonic, or subpulmonic. Interarterial course has the worst prognosis due to compression or kinking of the artery between the aorta and the pulmonary artery, especially with exertion. And that's how they can present with chest pain, syncope, or sudden death as well. Also, the coronary angiogram is a gold standard for diagnosis. 3D CT or MRI is also helpful to determine the details of the coronary anatomy as well. There is no consensus on the management of the single coronary artery anomalies. Usually the patient treated with medical management, but surgical management should be conserved in young patients because that's the second most common cause of sudden cardiac death in those populations. Our patient remained asymptomatic all this year, even he was 70, so till 7 decades he was completely asymptomatic. So, and even he do have interarterial course, he could have compression with exertion as well. And due to lack of the association of symptoms and his preference, so we opted for medical management. Anomalous coronary artery is usually diagnosed at very early age if it has a malignant cause due to exertional symptoms, but our case was unique in that sense. So take-home point is to rule out coronary anomalies in the patients with angina or exertional syncope, second most common cause of death, and manage appropriately in young patients either by unroofing or bypass surgery. Conservative approach should be reserved for special cases like in our case with late presentation and asymptomatic. So this case reminds us one of the presentation of coronary artery anomalies. Thank you.
Thank you very much. I guess the low-hanging fruit here is about stenting of a vessel that runs between the great cardiac vessels. What do you think, Manish? We'll assume that he's symptomatic and something needs to get done. Would you consider stenting that?
Yeah, the problem I have with these patients is it's hard to know what their symptoms are often from. I mean, this gentleman is in his 70s. You know, I had a patient about 6 months ago that had left main disease and garden variety angina and had, you know, an aberrant left main off the right cusp traveling between the PA and AO. And everybody and their mother wanted to bypass him. And the guy's like, I don't want to bypass. I'm 70 years old. A garden variety cardiac disease, you know. So the answer is, I mean, if it's truly from compression, I would graft these patients. I don't think stenting them is the right thing. But how do you know? How would you know? And that's really the decision-making dilemma here.
Questions from the audience? Well, I want to thank all the fellows for fantastic, fantastic cases, really entertaining and educational. Thanks so much. Thanks everybody for attending, and enjoy the rest of the program.